3, 2, 1.
Good morning, everybody. My name is Ian Trenholm. I'm the Chief Executive of the Care Quality Commission. Thank you very much for coming this morning to our strategy launch webinar. Firstly, I want to acknowledge the vast numbers of you, many of you who are listening today, that have contributed and responded to the consultation. This strategy feels like a team effort, powered by the voices of the public, those who work in health and social care, and of course my own team. So a big thank you to all of you. Let me introduce the hosts for today's launch. I'm Ian Trenholm, I'm the Chief Executive of Care Quality Commission, and joining us today on the call is Peter Wyman, our Chair, Kate Terroni, the Chief Inspector of Adult Social Care, Kirsty Shaw, our Chief Operating Officer, Nigel Acheson, our Deputy Chief Inspector of Hospitals, Rosie Benneyworth, the Chief Inspector of Primary Medical Services and Integrated Care, Kirsty, our Director of Engagement. And all of this is made possible by our fantastic webinar team, Jamal Wallace, Rachel Miller, Francesca Scott, and Steph Lowe, who's our event lead, who's going to make sure that, that everything happens as it should. Just a couple of quick housekeeping notes. If you're having any technical issues at all, please just use the chat box function in the Q&A part to let us know the issue, and we'll try and do our very best during the call to resolve it. We will stick to time, so we will stop the call. We will finish it at 11 o'clock, but that should give us plenty of time to introduce the strategy and to have a Q&A session as well. The way the Microsoft Teams live software works, and many of you who have been on these sorts of calls will know, is only the webinar team will be able to speak. So only those of us who are hosting the call will be able to speak, but we'll take questions in the chat function in the side there. You can ask you can use the chat function at the side of the screen to ask any questions at all, and the team will respond on the chat, or we'll answer them in our Q&A panel session later. It would really help us if you could use your name and organisation when typing out a question. It means we can frame our answer in a way that's going to make the most sense for your sector or your organisation. We will be answering questions about our strategy today, and only really our strategy. And any other questions we'll note, and the team will get back to you separately. And some of the questions we'll try and answer quickly in the chat if we can. But those sorts of the questions that lots of people are interested in, we'll try and answer those verbally if we can. So if you see a question that's very similar to one you were going to ask, please just like it, and we'll ask the most liked questions where we can. The webinar is being recorded and it will be updated to our YouTube page, so please feel free to share this with colleagues or other people in your networks that you think might be interested. And of course, we will circulate the presentation slides to you afterwards as well. So let's get into what we're going to cover today. We want to start off with our role and purpose, introduce the strategy itself, talk a little bit about who's been involved in the development of the strategy so far, hearing from our executive team about the detail behind the different elements of our strategy, talk a little bit about year one priorities, and then move into a Q&A panel when all of us will be able to answer questions, and then finishing up with next steps and how to stay up to date on where we go from here. I'm now going to hand over to Peter Wyman, our chair, to talk about our ambition. Peter, over to you.
Thanks, Ian. So CQC has come a very long way since we were formed a little over a decade ago. It's important, though, that we continue to evolve, which is why we are changing how we regulate to improve care and services for everyone. Our purpose and our role are not changing, but as we respond to how services are changing, how we work will be different in the future. The way we regulate will be more relevant to how care is delivered and will be more flexible to manage risk and uncertainty. What you will hear from my colleagues this morning is how our new strategic direction has developed. It's an ambitious strategy which responds to how health and social care continue to evolve. Thanks, Ian.
Thanks, Peter. So, in terms of how we got here in terms of our new strategy, we thought we'd just spend a couple of minutes just talking about that. So I think we felt that to develop a really relevant and inclusive and collaborative strategy, we needed to start a conversation with the people that use services, the public, the people that work in services. So we started that conversation about our future back in September 2019 to start to really fully explore what excellent health and social care regulation could look like. We ran a series of events during 2020, finishing up with a full consultation between January and March of this year. And despite restrictions on the face-to-face activity due to the COVID-19 pandemic, we had excellent engagement. I think what was really good was what we heard from people was overwhelming support for the overall direction of travel of the strategy. Over 75% of respondents fully or mostly supported our proposals. There was support for our emphasis on hearing the perspectives and experiences of people that use services. And people welcomed the focus on us working more closely with services and building strong relationships with them. There was also support for ensuring up-to-date and accessible information was available to help people make better choices. And there was also support for sharing good practice. We know we have the privilege of perspective right across the health and social care landscape, and we want to find ways to share that with providers more effectively. And the pandemic, of course, has shown us how delivering care using digital methods can work effectively for some people. And this strategy helps to further build on the idea of encouraging innovation. The main thing, though, that people wanted to know more about was how we were going to do all of this. We have a significant program of change which has been running for the last couple of years, which underpins the strategy. And we will see changes to the way we work and organise ourselves and use technology over the coming year and beyond. And colleagues will talk a little bit more about that later on. Our strategy starts with the idea of regulating through the eyes of people who use services. So let's hear from two people who have experienced health and care services. And I'm going to hand over to Alexis Quinn.
Hi, my name's Alexis Quinn. I'm autistic. I was detained in hospital for 3.5 years. I was subject to a lot of restrictive practice, including routine restraint and seclusion, also long-term segregation. And I ended up actually having to flee the country whilst I was on the section. And I've written a book about it called Unbroken. And I'm now pleased to work for the Restraint Reduction Network. And to support CQC in their efforts to improve the culture and quality of provision for people receiving care. Now, I've been involved with the RSS review on the EAG for that group, and on the back of that work, spoken at a number of events, including some conferences and parliamentary events for that. And more recently, I've been on the EAG for the closed culture work. As part of my work for the RRN, we carried out some consultancy work on behalf of the CQC, and we heard in the form of surveys and also forums from close to 400 people about their experiences of closed cultures. Now, some of that information was like really hard hitting, even though I've experienced the harsh end of the system. We need to see more people being cared for in the communities, obviously. We need to expect, as a matter of course, timely responses to trauma and crisis. Often these start out as social problems and they become medical problems because the community isn't kind of proactive. Yeah, at the moment we're in a situation, aren't we, where things are reactive. We leave things to the very sort of last minute, and this is what invites detention, and this is what invites restrictive practices. Also, I think communication, this is something we can do fairly easily, needs to flow between services, and the trained workforce then needs to be able to help, yeah, and not hurt. And then moving on to safety through learning, a lot of this is about driving culture change. The CQC can influence this by ensuring, stronger safety in cultures. And if the CQC expect the service's primary response to be learning and improvement to safety concerns, then this is going to have to make services, isn't it, step up if they want to get a good rating. And when safety doesn't improve, the CQC have got to have the teeth to do something. They've got to be willing to use them, you know, and only in doing that can they take action to protect us. So look, you know, I hope the CQC drives these areas. I hope people who find themselves in situations like I did, you know, where they need care, and that they get that care, you know, that they deserve, you know, and I hope that services see us as people.
My name's Isaac Samuels, and I live in the east of London with my partner and 4 dogs. I have had many years of experience of kind of mental health services and systems. I've spent many years in and out of hospital. So I was aware of the work that the CQC was doing, but not really fully understanding what their role was. So when I became involved in the project around close culture, one of the things that was really important to me as someone that has experienced close culture and really poor care was that how do lived experience stories, so the stories of people like me, really support the CQC to really inspect services in a way that makes sense, not only to the CQC but to people that are in receipt of those services, and ultimately prevent close culture and poor practice happening in the first instance. I think the work that I've done alongside the CQC is been really refreshing, because I think being in a space where inspectors talk about their own difficulties around inspections and close culture, and it felt like it wasn't a them and us thing. It felt like we were working in a way that we wanted ultimately mental health services to be the best possible services. And there was a role for the voice of lived experience working alongside inspectors to make that happen. And I think for me, what good would look like in the future would be the CQC using lived experience more extensively to support inspections, to help drive up quality, to prevent poor practice, but really that partnership working between those with lived experience and learned experience coming together, because I think together they're really strong at recognising some of the challenges that health and social care systems and services have. I think what was really nice in the work that we did was hearing from the inspectors about, you know, what an inspection looks like, how they do the inspections, what they're looking for, but the lens of the inspector will be around some of the domains they were talking about, but that lived experience voice is so important within that. So I think it's a great opportunity going forward to get it right from the start.
I'm really grateful to Alexis and Isaac for sharing their views. I think really strongly making the case that health and care is much more than about the performance of a single provider. It's much more complex than that, much more nuanced than that. And they were talking, I think, about what is possible when lived experience really drives improvement, and what is possible when services come together. And that's the essence of our strategy. I'm really grateful to them specifically for the work they have done with this in a really practical way to help improve the quality and culture of services. So our strategy has 2 core parts to it. We have, in terms of our strategic themes, we'll continue building the underpinning systems and structures and making changes in the way that we work to enable our strategy to come to life over the next 2 to 3 years. But of course, full realization of the strategy will take longer as we continuously learn and evolve, responding to changes in the world around us. And some of that's predictable, but of course, as we know from the last year, some of that is really not. I'm going to ask my executive team colleagues in a moment to start to take us through each of the strategic themes. First, there's the core ambitions that run throughout all of the themes, and they are about assessing local systems and tackling inequalities in both health and social care. Those core ambitions run throughout each of the 4 themes. And then there are 4 interlinked themes that will determine the changes that we will make. They are people and communities, smarter regulation, safety through learning, and accelerating improvement. And I'm going to hand over to Chris Day, our Director of Engagement, to talk us through the core ambitions. Chris, over to you.
Thanks, Ian, and good morning, everybody. I think my colleagues will talk through the 4 strategic priorities in a moment, but I want to focus on those 2 core ambitions. Over the last 12 months, I think it's reiterated to many of us how much one organisation can impact another in a local area. And I think our ability to provide independent assurance on the quality of care in the area has never been more important, something we began probably in 2019 with the system reviews. To do this, we will look at how services work together in an area as one system to deliver better and more coordinated care, with a particular focus on how well led system partners are and how they perform well together with people who use services in a community. We want to improve the way we assess how local systems think and act together to enable people to speak up and build confidence in the services that they're provided. And to do that, we need stronger relationships with local groups, with local services and with local system partners, and to have an ongoing conversation about the quality of care and their access to care in an area. This, I think, will in turn help us understand the quality of impact of how people receive services, not just the quality performance, but also whether there's any inequality in people's access to care. And with that, help us target more appropriately improvements that we need to see in a local area. To do this, we'll assess how local systems understand the needs of their local population, especially people who face the most barriers to accessing good care, and for those with some of the poorest outcomes, enabling the local systems to address their inequalities more effectively. We'll work with others to develop a shared understanding of the factors that contribute to inequalities and influence others to reduce those inequalities through better experience, through sharing what's working well in some areas. Experience and outcomes and outcome measures of care, I think, are really, really important in this space. And if this is not just about health, it's also about health and social care acting and working together. Encouraging continuous improvement in the quality of care has never been a clearer ambition as we enter a sort of a new COVID age. And it's clear that we need to understand what the standards are for that care and how people who use services what they can expect in their local area. I'll now hand on to Rosie, who will talk through in more detail the first of our strategic themes, people and communities. Rosie.
Thank you very much, Chris, and good morning, everyone. I'm just going to talk about people and communities, one of our themes, and very much building on what Alexis and Isaac talked about earlier on. We want to regulate by looking through the eyes of people using services. We want regulation that's driven by people's needs and experiences, focusing on what's important to people and communities when they access, use and move between services. And we think that's really important, building on what Chris was saying. Quality of care that someone gets partly relates to the service, one service, but also relates to how multiple services work together. We want to be an advocate for change, with our regulation driven by people's needs and experiences rather than how providers want to deliver them. This means focusing on what matters to the public and to the local communities when they access, use and move between these services. Working in partnership with people who use services, we will have an opportunity to help build care around the person. We want to regulate to make that happen. We will reach out and gather more experience from a wider range of people and make it easier for people to give us feedback. There'll be better analysis and use of people's experiences in our assessments. We will have a clear definition of what good and outstanding care looks like for everybody, based on people's lived experience of care and what matters to them. And we will focus on how well services and local systems understand and meet the needs of the local population and the things that matter to the people in that local community. I'm now going to hand over to Kirsty to talk about smarter regulation.
Thank you, Rosie. So as Rosie said, I'm going to talk about smarter regulation. So what does smarter regulation mean? Well, it means we want to deliver a more dynamic and flexible regulation that provides up-to-date and high-quality information and ratings. It also means an easier way of working with us and a more proportionate response. So what will we be doing in this space? We will be smarter in how we regulate. We'll keep pace with the changes in health and care, providing up-to-date, high-quality information and ratings for the public, providers, and all of our partners. We'll regulate in a more dynamic and flexible way so that we can adapt to the future changes that we can anticipate, as well as those ones that we can't. Smarter use of data means we'll target our resources where we can have the greatest impact, focusing on risk and where care is poor, so that we can ensure we're an effective, proportionate and efficient regulator. Site visits are vital in our assessment and essential to observe care, but they're not the only way to assess quality. They will remain a key element of our regulatory toolbox, but going forwards, we will use all of our regulatory methods, tools and techniques to support robust and proportionate decision making. Up-to-date and high-quality information will reflect how people experience care, so ratings will be more dynamic and meaningful, so that service users can be confident that the rating is reflective of the care they're likely to experience on the day that they use that service. We want to work with providers to build supportive and constructive relationships, which will minimise unnecessary workloads associated with regulatory activity. And finally, we want to work with our partners to coordinate data collection and data sharing so that we reduce duplication for providers when collecting and submitting data to us and other organisations. We also want to be able to collect data in such a way so that we can collect it once and use it many times and extract maximum value from the information that we hold. I'm now going to hand over to Nigel now, who's going to talk about safety through learning.
Thank you, Kirsty. So our safety through learning theme will see us regulating for stronger safety cultures across health and care, prioritising learning and improvement and collaborating to value everyone's perspectives. For learning and improvement to be the primary response to safety concerns, staff must be supported to work in a psychologically safe environment, one which is open, it's transparent, it promotes candour and is curious to understand how services can continuously improve, either in response to concerns about safety or by using data to support and test change. We will check on the presence of these conditions, and in particular where there's a risk of poor culture going undetected, and we will act quickly where improvements aren't quick enough or if they're not sustained. We'll also work with other stakeholders to agree a language and a definition around safety, and we want staff to feel confident that we will listen and act on their concerns and intervene quickly where appropriate. It's important that people are empowered to become active partners in their care, and we will check that services actively take into account people's rights and unique perspectives on what matters to them. So I'm going to hand over now to Kate.
Thank you, Nigel. Good morning all. I'm here to talk about accelerating improvement. So we all have an ambition that people receive high quality person-centred care regardless of where they are in the country. So we want to do more in the improvement space as part of our new strategy. We want to do more with what we know about what drives improvement, what enables providers to deliver high quality care and sustain that high quality care. We want to use our unique position to shine a spotlight on priority areas that need increased focus and support to drive up improvement. We want to ensure that we empower providers to use the information and the support available to them to deliver that quality care for people. We will obviously use our regulatory role and our powers to act where we see poor care. But our focus is about collaborating and strengthening our relationship with people who use services, providers and our partners to make sure that improvement can happen. So we want to identify gaps in improvement where there's support needed across health and social care. We really want to get to a place where, regardless of where you are in the country, the size of your organisation, the type of care or health or care that you provide, that if you need support to improve, you can have that support, that you are able to access it. So we won't duplicate where that support offer is already available, but where there is gaps, we want to facilitate national improvement coalitions to bring together partners to really make sure that there is that offer of support for everyone delivering health and care across the country. We absolutely want to encourage and support innovation. You know, we've seen vast acceleration of technology-enabled care over the last year, and we want to see research happen which leads to benefits for people. So we want to support that innovation around technology, research, etc. And we want to be proportionate in our approach to how we regulate them. And finally, we want to embed a continuous learning culture in CQC, focus on evaluation and understanding that we maximise our efforts where it's having the biggest impact on supporting you all to provide high quality care for people. So I'm going to hand over to Chris to summarise the themes and to talk about the outcomes. Over to you, Chris.
Thanks, Kate. So having heard a bit more about our strategic ambition, this slide tries to bring it all together in one page. By delivering the aims and the ambitions of the strategy, we hope to achieve 12 outcomes. But let's quickly just cover some of the themes of those outcomes. Firstly, our activity is driven by people's experience of care. I think there's no more powerful lever for change than the voice of people using services, and we'll use this to help promote what's working well, as well as change is required to health and care services. We also know that there needs to be clearly defined quality and safety standards in line with people's changing needs and expectations. This definition should be used constantly by all people at all levels in health and social care, and it's important that we can set out what that looks like, building on our work 5 or 6 years ago with key lines of inquiry. For providers and system leaders, we know that we need to be proportionate, targeted in our approach, but we also need to provide up-to-date, reliable information to give an accurate picture of quality as it changes over time. For the public, we know this must be relevant information which is in an accessible form and useful to them in making decisions, and also to be clear about the services that they are being provided. And we know that improvement in quality that we're seeking to come as part of this comes from a culture where local systems work together for the benefit of people and where everybody can contribute equally. We must contribute to this culture by providing a safe space for people to provide information to us so that we can demonstrate learning and we can support learning in organisations and local systems. And we need to be a good partner in accelerating improvement, working with different players in different parts of the system in partnership to encourage providers and local groups to drive meaningful and substantial change in their local area. I'll now hand back to Ian, who will talk through our priorities for year one.
Thanks, Chris. We know that one of the challenges from those who responded to the consultation was that they liked our strategy, they liked the ambition, but wanted information on how we were going to make that a reality. So each year we'll set out our priorities for implementing our strategy, and in year one, working in partnership with others, our focus will be on developing how we monitor risk and test out a new assessment framework. This will allow us to look at the quality of care across a local area, as well as at a provider level. We want to pilot our new assessment framework so that we can fully understand how best to identify the underlying factors which impact the quality of care. And of course, in developing a stronger understanding of what impacts the quality of care, we'll use our insight from this work to drive improvement, using things like our independent voice reports. And this will be supported by the development of a new provider portal and a mobile-friendly website, so providers, strategic partners, and the public can access our information more easily. We will carry out further research and engagement to develop our collaborative work on safety and improvement. This will include looking at how we can use our convening power to bring together improvement coalitions, particularly in sectors where improvement support isn't really there. We'll also work with partners to agree a definition and language about safety across sectors. We will be clear about how we will regulate safety cultures and empower services to improve. Exploring our approach to assessing how local systems understand the needs of their local populations, especially people who face the most barriers to accessing good care and those with the poorest outcomes, will be also an important part of what we do in year one. So thank you for your support in getting the strategy to this stage. And I'm going to hand back to Chris Day to lead the question and answer session. Chris, over to you.
Thanks, Ian, and thanks to people who have already put questions into the chat. You can use the the Q&A function to put questions into the chat. And what I'll try to do is theme some of the questions that are coming through to us so we can give you a response. What I would say is that there will be a number of opportunities. So today is one opportunity. We will also continue to feedback through the work that we do over the next few weeks and months. The other thing I'd say is that this is the launch of our strategy today. So a lot of the questions that people are asking are actually some things that we intend to develop in partnership with you over the coming weeks and months. I'll start with the question that Liz Jones of the National Care Forum asked. It's about smarter regulation, and it's a theme that a couple of others have picked up on. With the greater focus on smarter regulation, the use of data, how will CQC guarantee the quality and robustness of the data, and what commitments are being to share that information in a transparent way? I think this touches on a couple of questions that we've had around both the provider portal in terms of how we share that information and in terms of how we pull that information in. Kirsty, do you want to begin with that, and then perhaps others that may want to add something to it as we go through?
Yes, thank you, Chris. So we know that data and collection of information has been is an ongoing burden, and we want to work with partners. So we are having conversations with NHSX and NHSINE and other partners around how we can set up and establish a data alliance where we can work collaboratively to collect that data in and make best use of it and share that around. That work is ongoing, and I'm hopeful that confident that we will be able to establish a good way of working to help minimise that piece of that burden. And I think as we get more into this way of working, we will get better at harnessing and collecting data. And I know there's some comments around social care where there isn't as much data available. But I think as we start to use more data and we start to harness information as well from the public and through our systems, we'll be able to start to build up a really good picture of services across the country. But that will take time. We're keen to start to work in this space.
Thanks, Kirsty. There's a sort of a linked question to that, which is about, with the increase in information which comes from people who use services and obviously colleagues who work in service, how will CQC balance the approach when it may be that there's a question that describes unfair negative feedback from individuals on social media or from people who are disgruntled in their employment. Just before I pass over to colleagues on that, what I would say is that some of the most potent feedback we've had over the last year have been from not disgruntled employees who are leaving, but genuine concern from people who are working in services today. And I think it's important that we can reflect on that, because that is probably one of the best ways to drive change and improvement. When we see organisations that move from inadequate or requires improvement to good or outstanding, they always do that on the back of the voice of their own colleagues, as well as the voice of people who use services. But to get that balance right, I wonder, colleagues, if I can ask for a view on that. We'll start with one of the chief inspectors.
Yeah, I'm happy to come in. Chris,
shall I go?
Oh. Let's do Kate first and Rosie, if that's okay. Yeah.
Thanks. So it's really important to recognise that all of these different sources of data, intelligence, information helps inform our view of quality and risk. So the data we get is really important. What's incredibly important is the increased amount of feedback we've had from people who use services, their families, people who work in social care, as Chris has mentioned. You add to that the conversations we have regularly with providers, with local authorities, with clinical commissioning groups, and all of that helps inform our understanding of what's going on within a service and where there may be concerns or where there may be best practice. And people on the call may be aware, but the increased focus on hearing directly from people over the last year. So our joint campaign with Health Watch England and other partners, the Because We All Care campaign, has led to a notable increase in information we've received, and actually 54% of our responsive inspections have been informed by information from the public. So no one source of data is the driver for action we take. It kind of makes up a rich tapestry of enabling us to have the best view that we need to have on quality and risk out there. Thanks. Over to you, Rosie.
Thank you, Kate. And just to build on that, I think part of our strategy is very much looking at how we get that really wide viewpoint from a whole range of different people using services. And as Kate says, we need to triangulate that with a range of other information as well, such as outcomes, clinical outcomes, and a variety of other services. So we very much balance it with all of the data so that we can get that very rounded picture.
I mean, from a hospital's perspective, I think there are, I mean, the data and the information from people who use services is something that we're exploring much more. And in fact, I'm on an inspection today where one of the key questions is how the service is engaging with the population who are using those services. But equally, there's information that comes to us from national clinical audits. For example, that's information that's been coming to us for some time. But just to pick up on what Ian said about our convening power, what we were interested in was talking to partner colleagues who run some of these audits to see if we could pick out through the pandemic the most relevant metrics, the most timely metrics that would help us and the rest of the system try and make sure that services remain safe and provided high quality care. And so those are some of the ways I think that already we're beginning to explore what our new strategy could look like in terms of how we use information and data.
That's really helpful, thank you. There was a couple of questions as well about are we going to change and adapt our key lines of inquiry, the way in which we put an assessment framework together. I think one of the most powerful things that we did a few years ago now was to bring providers and people who use services together in one place to have a view on what good looked like in services. And I just wondered if colleagues would want to talk to how we intend to adapt and change that view of the quality of care. I don't know if, again, yeah, Ian, do you want to start?
Yeah, if I could start us off, and I know the colleagues will join in. I think if you look at the strategy in overall terms, you know, this is very much an evolution of the work that we've been doing, and I think we very much recognise that we've learned an awful lot over the last few years. We've been able to benchmark providers. I think there's the way that we work is well understood in things like ratings, our 5 key questions. People understand what they mean. So what we'll be doing with the new methodology is building on that, and I think there'll be lots that will be familiar, but equally we'll want to make sure that we are only measuring the things that really make a difference, and that as services evolve and service models evolve, and as we come out of the pandemic, that we continue to evolve those key lines of inquiry in a way that makes sense for the times that we're in. I don't know whether other Chief Inspector colleagues in particular want to talk a little bit more about that.
Yeah, I'm happy
so
to.
I'm happy to.
You go first, Rosie.
Sorry, Kate. I was just going to say, I think there is a need. Over the years, our key lines of inquiry layered on, and we've got a large number of them now. I think we want to look at how we can simplify that to really look at the things that matter to people who use services, that really matter to their outcomes, and really pick up any risk and any harm to them. And we are undertaking that work at the moment. I think we're very keen to understand how, as regulators, we really drive that improvement of quality, and how what we look at through our key lines of inquiry drives the right data to be measured and the right things to be looked at. So there's a focus on real quality improvement throughout all of the sectors that we regulate. Great,
thank you, Rosie. There's a couple of conversations about how regularly we'll go back to services, and particularly organisations that are currently requires improvement. And there's also, on the other side of that, there's a conversation about burden for providers and the balance of inspection and gathering information in other ways. I wonder if, just to touch on that first point around, I think there's a particular question about is it our intention to continue to go back to requires improvement services? I wonder if the Chief Inspector could just give their perspective on that, and then linking that point about burden and how we balance the going into services and what it will mean to cross the threshold in the future. Again, happy for.
Shall I start from a hospital's perspective? So I mean, I think that picking up on the point that Rosie made just a second ago, I think that looking at, for example, all of the elements of our framework for the things that we want to explore with providers, and then working out which of the regulatory toolboxes those elements best fit into. So picking up on the smarter regulation piece, and particularly our better use of data. So the burden piece for providers, I think, 5 years on from, or 6 years on from NHS England being established, for example, there are now much better data sources coming from providers that we're working very collaboratively with other national stakeholders to try and see if we can use the same information so that providers don't have to repackage information for us. And in fact, that's exactly the approach that we've been taking during the pandemic, that where we've been out to inspect services and we've asked for information, we've asked for the information in the form that they have it in, so that they're not having to go to extra effort to package that up for us. In terms of going back to providers, I think that that's something that we will again be collaborating and working with partners to see. As Kirsty said, there will be occasions where crossing the threshold is absolutely the right thing to do, because that's the only way that we can make the particular assessment that we want to do. And again, I think we've been able to trial that during the pandemic, by really thinking very hard, if we're crossing a threshold to do an inspection, about what are the elements that needs to contain in a focused way that we can only get from crossing threshold. So I think we're at the we're on that journey, as it were.
Thanks, Nigel. I don't know if Kate or Rosie, if you have anything additionally you want to say about that.
Yeah, so I think we've learnt a lot over the last year about what needs to happen in person on site and what can be done through gathering information, through conversations with people who use services, families and providers. If I think in adult social care, we've had our pilot about our approach to home care inspections, and we've learnt a lot about how we can gather really rich information virtually through speaking with people who receive care in their own homes. However, we also know the importance of observation and being on site and immersing ourselves in a service, and sometimes visiting at different times of the day, so we really understand what it feels like to receive that care from the person's perspective. So this is about, as Nigel and Kirsty both said, this is about using the right regulatory approach depending on the risk and the type of service.
And can I just add,
sorry
Chris, just a final quick point in that, just to say, we know how busy services are. We know that services are under such huge pressures at the moment, and we want to make sure that we work with providers as efficiently and effectively to reduce any burden on that service. And we can do that, as Nigel said, through reducing duplication of data requests, through working with other parties, and through making sure that our systems and processes are easy and straightforward, and people are able to navigate those in a very easy way, and that's a key theme of our new strategy. Thanks, Rosie. There's a couple of questions which touch on both sides of closed cultures. There's a couple of questions about how well we will understand closed cultures moving forward in the new strategy, and then a conversation about whether we are transparent with providers about what we are seeing when we look at closed cultures. And I guess there's a balance to strike between making sure we can protect people who might give us information anonymously, and how we can deal with that, at the same time being clear with providers about what we're seeing in services. Kate, I know this is an area that you and your team are focused on. I wonder if you could give a comment to that.
Yeah, and if I can loop it back to the feedback we had from Alexis and Isaac at the start of the session. So we have really benefited from people who have experienced being inpatients, being in receipt of services where there was a closed culture, along with providers and other experts. So we have massively developed our approach to how we effectively identify potential closed cultures and how we approach regulation of those types of services, with a really strong focus on observation, and also an increasing focus on how we hear effectively from people who may not be as easily able to communicate as others. So really strong programme of work. We're currently trialling a new quality of life tool in some re-inspections of some inpatient services that are happening at the moment, and we will be looking at adapting that tool and shifting our focus to social care provision for people with learning disabilities and autistic people in the coming months as well.
Great, thanks Kate. There's a question from Paul about the provider information return. So I think the question is basically, will the provider information become a live document that is updated by the provider and CQC in tandem? At the moment, there's a heavy emphasis on providing information too. So I just wanted to give perhaps a view on how that might change moving forward. And again, Kirsty, I don't know whether you would want to start with that, but then bring in the Chief Inspector colleagues.
Thank you. So we know that provider information return takes up a lot of time. In an ideal world, what we'd like to get to is we can sort of tap into your systems live, so we don't actually have to. You don't actually have to do it. It's an automated process, and we can reach in and get the information that we need without you having to fill it in. That's our ambition. But I think as we start to move forwards, I think we want smarter ways of being able for you to be able to submit data to us. The new portal that we're establishing will enable you to be able to log on, update your data in real time, and so not having to go through the burden of filling in endless forms, and just keep your data up to date, and we can tap into that and use it as and when we need. So making that data collection process a whole lot easier than it currently is now, and reducing the time and the burden that's involved with that.
Yeah, and I think there's another question about the amount of information available. So historically, there has definitely been less information available in social care, but actually, the last 12 months taught us there is the ability to get more and accurate information on services in all sectors, including adult social care. I think that the challenge is, as to Kirsty's point of earlier, how do we harness it by working with other system partners? How do we gather information once and use it many times? But I do think that will be an important feature of how we gather and use information moving forward. There's a related question about, as we move into other areas of inspection activity, the knowledge of our staff and how they work and how they understand their role. Not only in terms of different types of services, but also in relation to system working as well as individual service provision. Clearly, that's a new area of work for us, and I know we've worked with people outside CQC to do some of the system reviews early in 2019-20. I just wonder if colleagues have a view on how they see the developing skills and knowledge of the CQC workforce developing as we have a more of a system perspective and obviously a more cross-system perspective in local areas. I don't know, Kirsty, if you want to start.
Can I come in on that, Chris?
Yeah, no, you go first, Rosie. Yeah, sorry, yeah.
So I think this is a really important point, and we've already started working with our teams to look at development in these areas. We had a lot of experience through the local system review programme. More recently, our teams have been undertaking provider collaboration reviews, working cross-system, understanding those relationships. We absolutely believe that we need the specialist knowledge and skills of each of those individual sectors, and that will not change. So we need specialists in hospitals and adult social care and GP practices, but we need to also continue to develop our workforce to really understand how systems work together and what good looks like in a system, and understand as well the data that will support the decision making that will lead us to those judgments about the quality of care in a system.
Thanks, Rosie.
So just to build on that as well. So I think, as Ian alluded to earlier, we have a fairly comprehensive programme of change that is underpinning this strategy, and a key area that we've been looking at are the core capabilities that we need in the organisation moving forwards to enable us to deliver on that, and that includes the capabilities of our people and the skills and knowledge that they need to be able to regulate effectively. And as Rosie says, specialisms are definitely here to stay. We're not looking to get away from those, but what we are looking at is, have we got some gaps in terms of the capabilities that we need, and then putting in a comprehensive plan in terms of how we get those capabilities, both building on partnership working in terms of how we work with our specialist advisors and our experts by experience, but also looking at whether we need to bring in new skills and competencies within our own workforce, and a good comprehensive plan about how we implement that going forwards.
Thanks, Kirsty. There's a couple of sort of building on that point. There's a couple of questions about our role in both ICS and local authority development. Obviously, the white paper is still being developed, but I think colleagues are looking for some perspective from us on how we see that role developing, particularly about the relationship between ICS's local authorities and individual organisations that we will inspect. I know this is work that's still ongoing, colleagues, and therefore there isn't a definitive plan as yet, but I wonder if we can give anything of our sort of initial thinking on this. Rosie, do you want to start, and then perhaps other colleagues come in?
Yes, certainly. This is work ongoing, and we're working very closely with lots of different partners to make sure that where we end up with systems regulation is effective and really drives the improvement across systems and really understands quality for people using services. So we are wanting to make sure that our role is around public assurance. How do we give that independent assurance about the quality of care in a local area, and ensure that providers in a local area are working together to give really good quality care and really understand their population needs, really understand what matters to their local communities, and how the providers work together and the commissioners in the local system to be able to deliver that. We are very much working with NHS England and the Department of Health and Social Care and other partners, because we want to avoid any duplication. We want to make sure that everyone has very clear roles and responsibilities, and we will continue to work with a variety of partners, many of whom will be on this call as we go forward to develop our regulation in this area. But we absolutely welcome the move towards system regulation. We think it's very, very important to look at this as part of our development. Thank you, Chris.
Thanks, Rosie. There's a couple of questions.
To say something, Chris, about
by all means, Kate, by all means.
So we know how interconnected the quality of care delivered by providers is with the commissioning arrangements, and I've seen some of the comments in the chat as well. So we really welcome the opportunity to look at how local authorities manage a market, work with providers, etc. But local authorities can only do a good job if they have a good relationship with their health partners. So the comments that Rosie's made about a role with ICS is critical also. So it's a work in progress, early conversations with the Department of Health and Social Care and local government. And again, we really look forward to expanding those conversations out when the time is right as we move forward with this work. Thanks.
Thanks, Kate. There's a number of questions about future involvement in this work, and I think I started this Q&A by saying that this is a launch of the strategy today, and many of the things that we want to do in the strategy will require the support and the development of colleagues on this call today, colleagues who work in provider organisations, who work with public and public groups and wider strategic partners. So see this as an open call for action in terms of the work that we want to do with you moving forward. Certainly just in terms of the practicalities, we will send you the slides which come with this pack today, and we will publish the full Q&A from today's conversations, including the questions that I haven't managed to get to today, because there are a number of them. I'm aware of the time as well. I just wanted to give Ian a bit more time, just to sort of to give us a sum up on today, where we are today, and also the next steps. Ian, if I can hand back to you, if that's okay.
Thanks, Chris, and thanks, colleagues. So just a final thank you to everyone for joining us today. Today marks the launch of our strategy. As we outlined in the presentation, we've been talking about this strategy for a while now. We think it's got widespread support. We think it's a sensible evolution and build on where we've come from, but also I think most importantly around the sorts of services that the public are increasingly wanting from the places in which they live. So thank you for the useful questions that people have put forward. I know there's lots of questions around delivery and how this actually plays out. I think we very much recognise that there's a lot of work to do to deliver on these ambitions. As Kirsty was describing, we have a very significant programme of change which has been running for a while now. So I think what that translates to, I think, is we are expecting significant delivery over the next year. But we need to also recognise, I think, that the country is in a time of recovery, personal recovery in terms of the people that work in services, because I know people say it a lot, but I think it can never be said often enough that the people that work in health and social care have done an absolutely tremendous job over the last 15, 16 months. And we as a regulator need to walk that very fine line between recognizing that need for recovery in terms of service recovery, in terms of personal recovery, but also making sure that the services that are being delivered are safe and of a high quality. And that's sometimes a difficult balance to strike. And at the same time, we have these ambitions for the future that are set out in the strategy. So this is complex work. It's complex work, and it will take some time, but I hope you will see some very practical changes over the next year as part of a multi-year program of work. So everybody, thank you very much once again, and have a great weekend when it comes. Thanks for your time. Cheers. Bye-bye.